I want to welcome you to Persyst Grand Rounds, which is an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I am Marie Terrell, Director of Product Management with Persyst, and I'm here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with you, the broader community, so they can share their expertise and knowledge so we can all grow together. Next slide, please. So the opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst, and Persyst is not providing any form of compensation. We welcome Dr. Stuart Tomko as our speaker for today. Dr. Tomko is a neurologist with special qualifications in child neurology. He received his medical degree from Baylor College of Medicine and completed residency in pediatric neurology at Texas Children's Hospital in Houston, Texas. Dr. Tomko went on to complete 2 fellowships, both from Harvard Medical School in Boston, Massachusetts, one in clinical neurophysiology and epilepsy, and the other in neuroimmunology. Currently, Dr. Tomko's primary focus is the clinical care of children with refractory epilepsy, epilepsy surgery, autoimmune encephalitis, CNS vasculitis, and inflammatory epilepsy. Additionally, Dr. Tomko is currently working to establish a national pediatric epilepsy surgery database focusing on the use of stereo EEG in epilepsy surgery. He also conducts research on the link between epilepsy and other autoimmune conditions, such as inflammatory bowel disease, and he has over 100 citations in a 10-year period. Today, Dr. Tomko is going to speak to us on going under the waves, macroperiodic oscillations in the ICU. Learning objectives will be to define macroperiodic oscillations, otherwise known as MOs, to visually recognize MOs on the conventional DSA, which are spectral density arrays, density spectral arrays, and finally to list the possible clinical correlations with this pattern. Okay, and so without further ado, we welcome Dr. Stuart Tomko.
Hi, thanks for inviting me to speak. I appreciate the opportunity. So those are the objectives. Just for my conflicts of interest, I do have images from Neon Codin, which is the EEG system we use, and I do have some images from Persyst. I have one off-label mention of medication, but not much off-label stuff. No financial conflicts of interest. And I will confirm Persyst has not reviewed any of these slides or given me any direction in this. So this is all my own, unreviewed. So before we start, this is a quote I like. So this is from a memoir by this guy who flew around in the back of these Navy Navy aircraft. And his job was to fly around and hunt for Soviet submarines. And so if you read it, it's fascinating because a lot of what he's doing is very similar to what I think we're doing with quantitative EEG, right? You can sit there and look at the waves on the surface of the ocean. But his job was to use all these technologies and quantifications to try to look under the waves and get more information. So he said they had to look beyond the data, the physics, and the engineering to find the personality and attitude of the signal detected. And that it made a well-trained eye, intellectually able operator with an artistic eye necessary. So hopefully we'll be a little more well-trained. I think we're all intellectually able and maybe get a little bit of an artistic eye for this. So before we get deep into the MOs, is what we say, the MOs, the MOs, which is an infraslow oscillatory pattern on EEG, I'm just going to kind of get our feet wet with quantitative EEG a little bit. I do assume that everyone coming to a Persyst Grand Rounds has a little bit of background knowledge on quantitative EEG, so I don't have much basics on quantitative EEG here, just with the assumption that if you're coming to Persyst grand rounds, you might know what a spectrogram is. So I think we all know, but it's helpful, at least for me, to review what we're looking at on EEG, right? Because we can look at the waves, but again, to look under the waves, to look under the surface, we kind of have to know what's there. So as I think we all know, an action potential, right, is the basic generator of electrical signal in the brain. And there's a couple things I want to mention here. So I'm not going to go through all the physiology, but it does rely on sodium channels, potassium channels, and these active ion fluxes, right? And it requires the appropriate intracellular medium and extracellular medium and the movement of the ions back and forth across the cell wall for action potentials to generate. Again, the physiology is not super important, but the clinical implications can be. So in order for neurons to function, there has to be enough energy to maintain the ion gradient for action potentials to fire. There has to be cellular integrity, so the cell wall has to be intact to maintain that resting potential that allows the action potential to happen. There has to be normal intra and extracellular milieu. So for all these things to be stabilized, there has to be enough blood flow, right? So the EEG relies on blood flow. And a lot of where QEEG has, so obviously seizure detection is one use of QEEG, but looking beyond seizure detection, a lot of QEEG has been used to examine this physiology, to examine the EEG biomarkers of changes in blood flow. Just to follow that train of thought for 1 second, the action potentials are so short and so low amplitude that we can't see them on surface EEG. So what we're seeing on surface EEG is the summation of action potentials into EPSP, so excitatory postsynaptic potentials. So the millisecond action potentials summate over time into EPSPs, and then we see oscillations typically over seconds on EEG, or hertz oscillations per second. We'll circle back to this at the end of the lecture, but I just wanted to mention that here. So again, a lot of what we're looking at on quantitative EEG beyond seizure detection is looking at how the EEG changes with relation to blood flow. And I think a lot of us are probably familiar with this now pretty classic table showing as you have decreased cerebral blood flow, the changes you see in EEG. So normal admixed frequency. As you have your decreased blood flow, you start to lose your faster frequency, so your beta, and even faster than beta for those looking at the higher frequency oscillations. Then you have accentuation of your theta, loss of theta and accentuation of delta, and then it goes flat after you infarct. Here's the cellular response resulting in these changes. And again, it's kind of what we just talked about. So you need the blood flow to maintain all the correct gradients and the correct physiology to generate those action potentials. Now this is showing raw EEG tracing, but you can obviously see that those changes in EEG on a QEEG. So here, as you have your decrease in blood flow, so here your blood flow is decreasing, you see those changes on the raw EEG. So you have normal mixed frequency here at a normal cerebral perfusion. You lose your flash frequency, so you have to drop out of that higher frequency beta range activity, accentuation of your theta range activity, and then accentuation of your delta range activity. It's not on this table, but after that, you have basically a flat EEG. So clinically, when we apply this, we might see something like this. So up here I have a rhythmicity spectrogram, the DSA, so this is your just basic density spectral array. These are both left over right, an asymmetry spectrogram, alpha delta ratio, left and right, alpha percent left and right, and a matrix called Q slowing, which is delta and theta over your total EEG power. And what you notice here is that on that right hemisphere, you can tell on the rhythmicity spectrogram, you don't have much of that mid-range rhythmic activity, both on the rhythmicity and the DSA here. That highlights well on the asymmetry spectrogram. And you can see on that alpha delta ratio that there is that right hemispheric alpha delta ratio is a little lower than the left. And this is a patient who I monitored on EEG who ended up having an MCA stroke. So this is a lot of what QEEG, I think, has been doing for us, and it's fantastic, right? It's great. And it does allow us, again, to look under the waves, look at the cerebral perfusion and kind of be a, I've heard it, non-invasive tool to investigate neuronal function. But I would like to take that a step further. So the anatomy of the EEG, these are the basic frequency ranges that we think about on surface EEG, beta, alpha, theta, delta. There's been a fair bit, especially in the epilepsy and epilepsy surgery world, of folks looking at faster than beta oscillations. So gamma, HFOs, ripples, with more SEEG and more invasive EEG, we're better able to detect those faster frequencies as markers of epilepsy in the epileptogenic zone and that sort of thing. Really, relatively recently, we've been expanding the other end of the spectrum, right? So instead of going faster than beta, going slower than delta. So what things oscillate slower than, not slower than 0 hertz, but below that delta range. And today we're going to investigate or talk about one of those things that oscillates below the delta range. So we will dive a bit deeper into the EEG signal and look what else we can find. So macroperiodic oscillations. So this is a pattern that we kind of appreciated here at WashU. One of our neurophysiologists actually was the first to kind of acknowledge it. It's a distinct pattern. It was initially appreciated on the density spectral array of patients in the ICU. As we'll see a lot, it oscillates over minutes, which is why we call it macroperiodic, because it is well below that kind of delta 1-2 hertz range. It's like 0.007 hertz. And anecdotally, seem to be in patients with difficult to treat seizures. Often it preceded seizures. So we would see this pattern come and then a patient would develop seizures and go into status. Or it'd be kind of admixed into a patient in status. So this is what it looks like. So here's raw EEG tracings up here. This is a 12-hour density spectral array. And this is what the macroperiodic oscillations look like. So it kind of has a comb-like appearance with all these little spikes going up and down. So this is all channels on a 12-hour time scale. This is O2 on a 12-hour time scale because it was most apparent in O2. It's a little better visualized here. But again, it was visible in all channels. This is a 1-hour time scale, so it's the same thing, just blown up a little more. And what I'd like to point out here is the black arrow is this EEG, and the gray arrow is this EEG. And so just looking at the raw EEG, it is not abundantly clear, at least to me, scrolling through this relatively quickly, that there is a fundamental change between these two patterns compared to some other oscillatory patterns where you really can appreciate on the raw EEG that the background changing between the two patterns. And so I think one of the kind of fundamental features of this is, yes, when I point out that the black is here and the gray is here, you can see maybe it's a little higher amplitude here. But again, just quickly scrolling through, especially given that this changes over minutes, it's not obvious that the change in the EEG background. So it's really not until you look at the quantitative EEG, in this case, the DSA, that you can obviously appreciate that pattern. This is another patient showing the total DSA and then by power band here. So this black line up here represents the period in which the patient had macroperiodic oscillations. And what I'm showing here is that it's an oscillation in power, not really in frequency. So the power is increasing and decreasing across all oscillation bands, which is somewhat distinct from other slow oscillations, like, for example, CAPE, which we'll mention a little later, really is more an oscillation in the delta power coming and going. This is an oscillation in the total background power across all power bands of the EEG. So you can see beta is doing the same thing that delta is doing. We have a peak envelope down here just showing the same thing. But again, that is another unique thing, so that it's not obvious on the EEG tracing. It's really, once you get to QEEG, becomes more obvious, and it's an oscillation in power across across all the frequency bands. So the first thing we did was kind of see who it happened in. So these were patients, 38 patients where it was visually identified. So patients that we read in our ICU here that we visually said had that pattern on their spectrogram. And then we had 329 controls recorded during the same period, same ICU, just without that pattern visually apparent on their EEG, and compared clinical characteristics. So a couple of things kind of stood out. One is patients with the visually identified macroperiodic oscillations tended to be younger. So their median age was 8 days versus 207 days. And you can see the range here is younger up to adult, like we had some near adult controls here. Also, in our initial cohort, it was strongly, intimately associated with seizures. So all 38 patients in which we visually identified it initially had seizures versus 22% of our control patients had seizures.
Dr.
That,
Tomko, since
yes,
since we're allowed to interrupt and ask
yeah,
questions, I do have
sure,
a question.
of course.
Are you, from your last slide, are you defining MOs then as oscillation of power across all frequency bands? So it's not the ultra slow of sub 4?
Well, so it let me get back to that when I try to
Okay. Okay,
quantify
great.
it.
I just wanted to make sure
Um,
that I'm still with
so
you.
this comes up. Yeah, so it depends on what you mean by oscillation, right? So it is so when we think it's kind of fundamentally different, right? Because when you think of delta, you think of this something called like delta power, right? And so what we're really seeing, it's really an oscillation in power, not a to to take a quantitative EEG analogy, right? So if you do your fast Fourier transformation on your admixed EEG signal, you pull out your delta, theta, alpha, beta, right? I don't think that you're pulling out a separate signal below these and your delta, theta, alpha, beta are off doing their own thing. It is affecting these. So it's kind of a meta oscillation in that way, in that these frequency bands are oscillating in power. Um,
And
I don't
that
know if I'm explaining that
results,
well.
that oscillation in power results in relative perceived increase in sub 4 hertz. Well, yeah, below delta
Right.
range.
So what you see is you really see an oscillation. And when I get into the quantification, I might explain this better. You really are seeing an oscillation in the quantitative EEG signal, not a clear oscillation in the raw EEG signal.
Right.
So I will get into quantifying this, which hopefully will answer some of those questions
Yeah,
on what
yeah. Okay.
exactly we're seeing.
Thank you.
But really, it's an oscillation in the background power across all frequency ranges versus, I think, in comparison to like gamma frequency activity, which your delta and theta are doing whatever they're doing. And you have gamma, which is a separate frequency band. This is distinct from that in that this affects your delta, theta, alpha, and beta, probably gamma too. I don't know. We don't
Okay. So it's
get
a
good gamma
phenomenon that's
signals.
observed across all of the frequency bands, and it's an
Right.
oscillation in
Yeah.
power.
Right. Yeah.
Okay.
Yes.
I'm with you.
Um,
Thank you.
yeah. Yeah. No, the last time I gave this talk, someone had a similar question. So I don't know. Maybe we should have named it differently. We're in Missouri, and so we thought this was clever at the time because it's MO, and maybe we were too clever for our own good. Actually, Dr. Guerriero, who's here today, is the one who named it. So you can feel free to private chat him all your concerns. I'm going to throw him under the bus. So, okay. So patients were younger, more likely to have seizures. The indication for EEG was more likely to be that they had seizures or events, or sorry, more likely to have seizures, more likely to have TBI. And so again, it was associated with seizures, so seizures make sense. 15% of the patients in this group, the indication was we have a protocol. If you have a TBI, you get hooked up on EEG. So what the indication was TBI versus 5% in the other group. And fewer patients in the macroperiodic oscillation group had a premorbid condition. So 90% did not have a premorbid condition, were previously neurologically normal before whatever event led to the EEG, versus 67% in our control. So about a third patients in our hospital had a neurologic condition. So putting that all together, it seemed to be in younger patients, previously healthy patients, and there was a strong association with seizures. Again, these are patients in whom we visually identified it and tried to describe it, but our next step was to quantify it. And so that's what we did next. And hopefully this will answer some of those other questions. So we had, at this point, 43 patients with clinically identified, so visually identified macroperiodic oscillations. And then we had a control cohort of 200 patients who underwent the SEEG, I'm talking about SEG, underwent ICU EEG, who did not have visually identified macroperiodic oscillations. And we looked between 0.001 and 0.03 hertz, so something between 33 seconds and 16 minutes. So it had a pretty broad window because we weren't totally sure what we would find at this point. So this is what we ended up doing. So this is just a raw EEG tracing, 5 seconds. It's displayed in a little bit of an unusual way here, but this is raw EEG. This is the DSA. So what we looked at before, you have frequency here, 0 to 22 hertz, and this is your elapsed time in minutes. So this is about an hour and a half of EEG, and you can see the macroperiodic oscillations here. This is a peak envelope of the DSA. Right, so for example, Persyst will give you a peak envelope of your raw EEG tracing, which is just kind of the highest power at any time, kind of outlines your EEG. This is a peak envelope of the DSA. So this was something that is not typically evaluated. The next step was a DSA of the peak envelope. So this is now a second level DSA. So this is a density spectral array of the peak envelope, and the peak envelope is made from that initial density spectral array. So we now have a nested, a second level DSA. And if there is something oscillating strongly on this first level DSA, so if you have something oscillating like this, what you get is a band on the second level DSA, right? Because that is a strong oscillatory pattern on your peak envelope. In this example, you can see the strongly oscillating band here at 0.007 hertz, which is about 2.4 minutes. And this is, again, it's a visual identification, but looking at it in another way. So one thing that's nice about this is you get this band, which you can see. Another thing that's nice about this, which when we talk about some clinical applications becomes relevant, is when you're doing this level of analysis, so when you're doing a second level DSA, it becomes more agnostic to noise in the EEG signal. So when we use this clinically, we're not hand selecting quiet epochs. We're not that ICU patients typically have or often have well-formed state cycling, but we're not looking at, slow wave sleep to make sure there's no myogenic. This kind of inherently deals with some of the noise problem. Obviously, anyone who's done research in EEG, there's always a signal to noise problem that's inherent in surface EEG, especially in the ICU, right? But this does a reasonably good job of getting rid of some of that noise without too much computation. So this is what we're looking at. So these are the patients who we visually identified as having macroperiodic oscillations. So each column here is a single patient. These are the patients who had the best oscillations. These are the patients who had the worst oscillations. The y-axis here is 3 minutes at the bottom, 30 seconds at the top. So like this patient here, like the only thing they really had on their EEG was something oscillating right there at like 0.01 hertz. And you can see here, and then even as we go down here, there's more admixed signal. So there's more going on in the EEG, but you can still see that band of oscillation. These were our controls. I'll explain what Qmax is on the next slide. But basically Qmax is a measure for how strong that signal is. And the important thing here is in our control patients, some of these patients had, once we quantified it, pretty strong oscillations in this band, which we did not see visually, even on the DSA, right? So we could detect it in some patients who it was not visually apparent when reading the EEG. And then a lot of our controls, as expected, didn't have it. So what is the Qmax? So that is the index of strength for MOS, the IMSO. And there's two things. There's the Qmax, which is how strong the signal is, and then QSP, which is how widespread it is. So here's a patient. So this is a little bit different. So the y-axis, so this is all one patient. This is minutes, 0 to 700 minutes. And this is channels, so 18 channels in this case. And this is the frequency band. So the more yellow it is, the stronger the oscillatory signal in the slow frequency band. And so we did basically a wavelet analysis. So looking at how easy it is to explain this signal. I have to conceptualize this computational stuff. So I kind of conceptualize it because I understand fast Fourier transformation pretty well, like a reverse fast Fourier transformation, where instead of breaking apart the signal, how easy is it to come up with an equation that explains this signal? So a patient like this, where it's just this oscillation, it's very easy to explain the signal. It's almost sinusoidal, right? And so that would be a very high Qmax, a strong signal. And then you also see it in basically all channels, so it would be very widespread. So this would be a very strong and a very widespread signal. This patient, a couple things. So this is a more complicated signal, right? So it's not that just near sinusoidal. So this would be a little bit weaker in that it takes more equation. It's more complicated to explain this signal. And it's also more focal, right? So these are divided by hemisphere, so left over right. So it's seen here more on the right hemisphere than the left hemisphere. So this would be a more focal and not as strong signal. And then this patient, this is a very complicated signal that would be quite complicated to fully define. And you don't really see it anywhere. So this would be a very weak, kind of globally weak signals. This is a patient basically that doesn't have this pattern, right? So you go from a global strong to kind of a focal weak to absent. And there can be mixtures of those, right? You can have a focal strong. So these aren't the only categories, but these are kind of, you can mix and match between these. So once we had that, once we were able to quantify it, then we could look at it clinically, right? So this is a little busy, but the important part here is that we divided patients by their PC-PC score. And for those not familiar with PC-PC, it's basically a standardized measure for outcome of patients in the ICU, where higher is a worse outcome, lower is a better outcome. And the black dots are PC-PC greater than 4, which is kind of defined as a bad outcome. And the white marks is PC-PC less than 4. This is further broken up by, was it visually identified or not? Was it found? That's not super important for this, but just the black ones are worse outcomes, the white ones are a better outcome. On the y-axis, we have the QSP, so how widespread the signal was. And on the x-axis, we have the Qmax, so how strong the signal was. And I think what you can see here is that most of the white is clustered down here with, as you get further along the strength and further along the spread, so the stronger and more widespread the signal was, the more black dots you have, so the worse outcome. This is the same thing, just the statistics. So it was statistically significantly different. So this is Qmax, so how strong the signal was. This is PC-PC less than 4, so good outcome, and PC-PC greater than 4, poor outcome. And it was statistically significantly different. So the stronger the signal was associated with a higher likelihood of having a worse outcome from the ICU. So stronger widespread with poor outcomes. And then the other thing that was interesting about this is we found it in about 14% of our control patients. So it is, even when you can't visually see it on the DSA, it might still be present. So our next step was to go a little further computationally. again, in the last one, we kind of were looking to verify what we'd already found, right? Or what we felt we'd found, where we saw a signal oscillating and we're trying to quantify what we saw visually. But we found it in some patients where we didn't see it visually. So we wanted to try to look for a way to more globally detect it. So this was 15 patients, 10 visually identified, and 5 from the prior cohort in which it wasn't visually apparent on that first level DSA, but there was a relatively strong Qmax, so it was present. And we wanted to try to quantify it without a priori knowledge of the frequencies of interest, or kind of find it without knowing what we were looking for, and then determine the strength and the distribution, and then add on top of that spatiotemporal resolution. So instead of just how strong and how broad is it, how does it change across time? And that was a new feature of this. So I'm not going to get into the math of this. If you're interested in the math, I would recommend checking out this paper because it gets very complicated. That would be a whole hour. But just I think one neat thing about this analysis is, so you set your minimum frequency and your maximum frequency, and the NM is the window, right? So initially the window was set to 40 minutes, which meant that we were evaluating frequencies between 0.008 and 0.0417 hertz, which we thought would be the clinically relevant frequencies, right? 4 out of our 10 patients had the strongest signal at the very bottom of that window, around 2 minute or 0.008 hertz. So one of the strengths of this analysis is we just moved the window. So changed the window to 80 minutes, and now we could evaluate between 41 minutes and 25 seconds. So again, you can use this algorithm to look at really any frequency of interest. We're using it for MOs, but this is a broader EEG analysis technique. Really intended to not go below 0.0008 hertz or oscillating over 20 minutes. But again, you can change that window, change your sampling. FS is the sampling frequency to narrow or expand or try to find what you're looking for. So here's a patient. This is one of the patients. Again, you have your time here. So this is a 12-hour file. You have your channels here. And then the color scale is the strength, the Qmax, the strength of the oscillation. So this is a widespread, strong signal, and that you see it in all the channel bands. Again, that's not new. We had done that previously, but what was new here was the spatiotemporal aspect. So is it occurring at the same time? Is there a lag? So this is just these data basically projected onto a head model. So you can see it's yellow everywhere. So there is a strong oscillation in all channels. And then this is the time lag. So if you put your C point here in the middle of the head, if it's yellow, there is not much time lag. And if it's dark blue, there is significant time lag. And here it's all yellow. So this is a global signal. So this would be, in epilepsy, we consider a generalized pattern, right? In that it's occurring across the whole head at the same time. There's not a propagation to it. It's not starting frontally and spreading backwards. It's just kind of everywhere at the same time. This is a patient who had focal macroperiodic oscillations. So again, this is left over right. So it's on the right hemisphere here. And when we looked at that, in terms of the spatiotemporal resolution, it did spread to the contralateral hemisphere. So here you can see it on the right. But we did see a time lag. So it started here and then slowly, not slowly, it's pretty quick propagation, I don't mean, but propagated to the contralateral hemisphere. So this would be, again, in terms of epilepsy, a focal discharge with propagation. So it does seem that we have can have both a more generalized pattern and a more focal pattern that then propagates. So once we did all that, we said, that's cool. That's a lot of math. That's a lot of equations, but does it mean anything, right? Because I'm a clinician, I like things to be clinically relevant. So we looked at it in the NICU. If you remember from that initial cohort of patients, it was more prevalent in the NICU population. So we said, let's see what it means in the NICU. So we analyzed 37 neonates with the pattern. 3 died, 10 were lost to follow-up, so we ended up having 24 in the final cohort with the Bailey outcomes. Moderate to severe neonatal encephalopathy over 36 weeks and admitted to the NICU within 24 hours of life were our inclusion criteria compared to 17 control neonates. And then the Bailey is an outcome scale for the NICU, kind of similar to the, not similar, but the same concept as PCPC, looking at kind of developmental markers and used as an outcome. So we had that at 18 and 24 months. And so control, Bailey lost follow-up and died, and there's just showing the clinical characteristics here, like patients who died had lower APGAR scores, but there's like nothing super exciting between the different groups here. So here is a table. So this is similar to what we looked at in the ICU with PCPC. So this is strength of Mohs, so Q max here on the x-axis. This is spread of Mohs, so QSP here on the y-axis. And then the dots are, blue circles are control, green triangles are moderate encephalopathy, and yellow squares are severe encephalopathy. And if I draw a line right here on the x-axis, that does a reasonably good job of differentiating normal patients, the blue circles, from encephalopathic patients, the green and yellow triangles and squares. Now, it's not perfect. There's one normal patient on the right of the line. There's 4 moderate encephalopathies on the left. There's this severe, which is a little weird. Not totally sure what to make of that. I think it's a patient whose whole EEG was so low amplitude that there just wasn't a lot of strength, because there wasn't a lot of strength in the EEG. But it does a reasonably good job, right, of just visually here differentiating the controls from the moderate to severe encephalopathy. So it seems like it's not just a random smattering. The other thing I'll point out is the strength of Mohs here. Yes, the higher you go, these are encephalopathic patients, but the controls, they're not 0, right? They don't have a Qmax strength of Mohs of 0. They have something oscillating here too. So there does seem to be some physiologic part of it, and that we saw it in our normal controls as well. We looked at outcomes. So this is a validated outcome measure based on neonatal MRI. And so we compared the macroperiodic oscillations to this validated MRI outcome measure. And what we found is, so this is cognitive, language, and motor at 18 to 24 months based on the Bailey. And at the cognitive part of the Bailey, the strength and spread of Mohs were both statistically significantly associated with lower cognitive outcomes. The MRI score was not, and the discharge exam score was not. Only the Qmax and QSP were associated with cognitive outcomes. Nothing was associated statistically with language or motor outcomes. But of all of these, the Mohs in cognitive was the only thing that reached statistical significance. So was better than a validated MRI score and better than the discharge exam score.
Dr. Tomko, I'm going to interrupt you. We have a raised hand here.
Yes.
So I am probably going to mess up the pronunciation of the name, but Ayman Al-Budi has a question. I'm going to allow you to talk right now, Ayman.
Thank you. Thank you for that great lecture so far. My question is about your previous slides when you put the comparison between moderate, severe, and the normal. Yeah, this slide. So from this one, as I understand it, the lower right corner shows higher strong and more focal Mohs. Is that right?
So this is,
no, the right,
down here would be a
right
patient.
lower.
The right lower. So
Yeah.
This is very strong and very focal. That's right. Yes, sorry. Yes, this is very strong and very focal. This would be very strong and very global. That's correct.
So
And
patients with the severe encephalopathy has more focal MOs compared to the control. As we can see, it's distributed, the control, right?
I think that's fair. Yeah, I think that's fair, in that we do see it kind of more global here. And again, in a physiologic pattern, I'm kind of making stuff up at this point because we're getting to the limit of what we've done so far. But in a physiologic pattern, right, if it's whatever's generating it, it might make more sense for it to be global versus if it's due to injury, maybe the injury's not totally. I mean, we think of HIE as a global injury, but it might not be truly global. And I have a slide looking at MOs and different injury patterns here coming up. But it's, yes, I think that is true. And I don't have a clear explanation.
But when you were talking about the quality of the waves, how they were very nicely sinusoidal, those were having better visually seen color, very yellow, when they are more distributed. Is that right?
Well, it depends on, yeah. So it depends on what you're looking at. So like here, each one of these rows here is in a single channel. And so you can see it here. So it's very, you can see it in this channel. So you can see it, but it is a focal example here versus here where it's more global. And again, these things can be mixed. I think it is true, though we don't have data on this that I'm aware of, that anecdotally, if it's focal, sometimes I think there is some relationship between the focality and the strength. But here, like in the neonatal population, our strongest patients, in terms of how strong the signal is, were relatively focal. But again, that's the difference between visual identification and quantification, and they don't 100% match up all the time.
Mhm.
Thank you.
Thank you. Thank you, Emin.
Was there another question?
I think that was the only one. I also have a question about this, but
course.
well, I could wait till the end. I don't want to derail you, but I
No, go
was
for
just,
it.
okay. So when you were looking at the adults who were previously healthy, but then had an injury that put them in the ICU, there were
Yeah.
more MOs seen in that population, but also MOs were associated with poorer outcomes. The same doesn't,
So none of this is really adult per se. So
but it was
the
okay, but it was the regular ICU, right? In those data.
it's the PICU. So
Oh,
this
okay,
is
I missed that
PICU or
part.
NICU. Yeah, sorry.
Okay,
Yeah, so this is
so
all PICU or NICU. It's all
got it.
it's all people monitored here at
It's all
Children's
children.
Hospital.
Okay, sorry
Yeah,
about I missed that detail. But then
yeah.
in the NICU data, your controls, they weren't previously healthy, right? Because they're in the NICU, so you can't really
Right.
say the same. They're just the control group.
That's correct. And you will see that there are even more conflictory data in the NICU. So the NICU might end up being, the neonates might end up, as with so many things in the neonatal world, being a unique population.
Yeah,
That is, the neonatal population might be different than a 10-year-old who gets in an ATV accident and has this
totally.
pattern too. So yes, I do think, and you will see, just as a spoiler alert, it wasn't associated with seizures in these data, which is fundamentally different than how we first described it, which is this is a pattern associated with seizures. That was not true in the NICU.
Got
And
it.
then,
Is it also associated with poorer outcomes in the NICU? It seems like not.
so it's associated, so the strength and spread is associated with lower cognitive measures on your Bailey. And so we used Bailey as our outcome here, and it was associated with lower cognitive measures. This is the sensitivity and specificity of combined death or significant disability. And the area under the curve for the strength of macroperiodic oscillations is 84%, 100% sensitivity, and 77% specificity. So yes, strength of MOs was associated with a decent area under the curve, 84% area under the curve with death or significant disability. The yellow here is the MRI score. It had an area under the curve of 82%. So similar to Moe's. Moe's was a little better, but 82 versus 84. And then the purple here is how widespread it is. That wasn't great. So the area under the curve here is only 46%. But the strength of Mohs specifically was associated with an increased risk of combined death or significant disability with actually 100% sensitivity.
Okay,
Does that
strength.
answer that
Can you
question?
go back to the NICU slide then with the purple,
Yeah.
yellow, and the so strength. So strength.
So
Okay,
that's
so
on the
got it. So they have lower strength, the controls.
yeah,
So
so the
okay,
strength is here on the x-axis. The spread is on the y-axis. I
yeah,
think the take-home point is strength is more important than spread, right? We looked at both,
yeah.
but
In the
it's how
NICU
strong the
population,
signal was.
would you also say in the NICU?
Yeah, so here's the PC data, and again, this was what I have here is Qmax, right? So this is differentiating PCs by the strength of the signal, and you can see it's statistically different here. So there's some, when you look at the graph, there's some signal, the spread here versus the strength here. But yes, I think that both in the NICU and in the PICU, strength is really what comes out as the most relevant quantifiable marker. So this is PC by strength.
Okay.
And then again, for your sensitivity area under the curve, the strength was clearly better than the spread here and was a little better than the standardized MRI measure. This gets a little bit some of the questions too. So this is looking at the strength and spread based on the pattern of injury. So on the MRI, so blue was no obvious injury on the MRI. This, I don't know, these are all kind of the same colors. I don't know, whatever, teal, was a watershed infarct. This was isolated deep gray injury, and this was a global injury on MRI. And nothing here is really statistically significantly different. So it didn't matter where your injury pattern was on the MRI in terms of how widespread or how strong your signal was. The injury pattern on MRI has been associated with outcomes. And so like a global injury tends to have worse outcomes than a watershed infarct. So it's possible that it's likely that this is looking at something different than just the pattern of injury, and really an argument for the fact that this isn't the macroperiodic oscillation isn't the best marker of outcome. MRI isn't the best marker of outcome. Exam isn't the best marker of outcome. Putting them all together is the best marker of outcome, right? You're looking at it from different angles. And when you combine all those data, that's when you can make your best prediction. So I don't want to be here saying don't get MRIs and don't examine your patients, but I think this is another tool, and it might be asking a different question, not just reflecting some of those other measures that have already been validated. This is, again, I already gave you this. So this is looking at the likelihood of seizures. So this is the strength and this is the spread. And there's no statistical difference in the likelihood of seizures or in the likelihood of having obtained phenobarbital. So this was very surprising to us because we initially described this or found this in patients with seizures. And so again, the NICU neonates, as with everything neonatal, seem to be a unique population and that it is associated with outcomes, but not clearly with seizures. So that's where we are kind of clinically with it. But it leaves some questions, at least for me. So we talked about our action potential, again, with the time frame of milliseconds here, adding up to your EPSPs with the time range of seconds and how sodium channels and blood flow can affect your EEG and change your signal. But what makes your EEG do this, right? What makes your EEG oscillate over 3 minutes? And I don't know, but I have some thoughts. So this is kind of a smorgasbord of interesting things we've observed. So this is a patient, a neonate, who I monitored in the NICU. This is the EEG tracing. And down here, you can see a pretty strong macroperiodic oscillation. So this is F4, F3, and all channels. This is a 12-hour file. So you see the macroperiodic oscillations. I don't have it here, but they're also seizures. Like this is a seizure admixed into the macroperiodic oscillation. So it had both that and seizure. So we gave the initial first-line treatment of phenobarb, didn't touch it. People love Keppra, so they gave some Keppra. Keppra didn't touch it. And they gave us lacosamide, and it like went away. ended up getting a second dose of lacosamide to kind of keep it away. But it resolved exquisitely with sodium channel blockade, and it did not respond to other first-line treatments for neonatal seizures. And we've seen this pattern repeat itself. So phosphonatoin in the PICU patients that don't respond to other medications seem to respond to sodium channel blockade. So it does seem more sensitive, more responsive to sodium channel blocking medications than other anti-seizure medications. I don't know why. That's an observation that we've had. We've also recently started doing a lot more multimodal recording. So this is just a QEEG panel. Here's the EEG. Here's all the things we're recording. And what this is ICP, cerebral perfusion pressure, CO2, respiratory rate, O2, and it's time locked with the EEG. And so we can look at how the EEG is fluctuating with these other physiologic measures. So this is from one of our papers. So this is heart rate, ICP, and EEG power. This is the decibels, so how strongly those things are oscillating, again, on a second level density spectral array. This is the frequency range. So here you can see 6 to 8 millihertz. And basically what this is showing is in this frequency range, the light here is parts of the EEG where there were not macroperiodic oscillations, and the dark is parts of the EEG where there were macroperiodic oscillations. Again, the Qmax is 0.75. When there were macroperiodic oscillations, 0.43 when there were not, just to throw that in there. And what you see is when the EEG has that signal oscillating, the ICP and the heart rate are also oscillating at the same frequency. So it is not solely an oscillation in the EEG power, it is also in other physiologic measures. And Marie, again, that's what makes it different from things like gamma or delta, where that is a distinct frequency on EEG. This is really a patient-wide oscillation in some ways.
It's a global phenomenon.
Right, yeah. So here's an example of it with heart rate. So here's, again, a 12-hour DSA. You can see the MOs very strongly in this patient. And here's the heart rate. And just to blow it up, you can see a 1-to-1 relationship with the EEG power and the heart rate. This is, again, to your point earlier, Marie, distinct from things like CAPE. So this is a patient with CAPE, which is cyclic alternating pattern of encephalopathy, where you have delta slowing, and then it kind of goes away, and delta slowing. And in a patient with CAPE, you can see that oscillation here in the delta, but it does not affect the heart rate, right? The heart rate's just doing what the heart rate's doing, even while you have that oscillatory pattern on EEG. So this does seem distinct. And we can expand that further now with multimodal. So this is heart rate, O2, ICP, and macroperiodic oscillations. And you can see as the EEG oscillates. And again, I'm not claiming any directionality here per se. I mean, I think the EEG is probably not. I don't want to claim any clear directionality, but you can see they're all oscillating together. So our working theory is that this is some failure of cerebral autoregulation, and so you get hypercoupling of cortical activity and cerebral perfusion. Don't know exactly why, but that does seem to be a hallmark of this, is that, again, it's not just an oscillation in the EEG signal, it's really an oscillation, a physiologic oscillation too. Going back to babies, babies have very fragile autoregulation, much more so than adults. And so if this does involve autoregulation, that might be the physiologic explanation for why it behaved a little differently in the NICU, because their autoregulation might be easier to break, or maybe in adults, outcome of not adults, but in older kids, when you break autoregulation, you get seizures, whereas in babies, you don't. GABA does weird things in babies. So again, this might be part of that explanation for why it's different in the neonates. But this is kind of our working theory. So in summary, inflow oscillations in the EEG power are associated with increased seizures and or worsened outcomes in some populations. So again, the NICU is different than the PICU, so nothing global. We can detect and utilize in real-time clinical care. So we have at times seen the pattern and elected to treat it in patients for whom we know that it can portend a higher risk of seizures. and it might be related to dysfunctional autoregulation. Future directions, so looking at it in other clinical settings, we've looked in the NICU, we have some data in the PICU, but kind of expanding, trying to figure out the physiologic basis, and then Dr. Guerrero is doing a lot of work kind of looking at other infraslow oscillatory patterns like CAPE and how they're different or related and that sort of thing. So that's a big area of interest for him. Some acknowledgement, so I could have done this without a great group of folks here. A lot of this was in collaboration with WashU School of Engineering. So they helped us with a lot of the computational part of this. And then folks in the NICU and PICU also helped with implementing some of this clinically. So that's what I have, and I'm happy to take any further questions.
Wonderful. Thank you. That was really interesting. So we do have some questions here, and I've got some questions, so we'll take them as they come. So there is also a Q&A. So there's a chat and a Q&A. You can type your questions in either box, and I will see them. You can also raise your hand and speak your question if you prefer that. In the Q&A, the first question, I may have missed it. I don't know at what point it came in during the talk, but the question is, so how could we measure those oscillations, or is it just the software?
Yeah,
Yeah.
we don't have a commercially available measure of it currently. We do have some IP stuff related to this. So what we use clinically is this. So we use visual identification on the DSA.
Yeah.
This is DSA from Neon Codon. Just to say, if you don't use, I know a lot of people don't use Neon Codon. This is a Persyst panel. And so you can see it, there's nothing fundamentally different between a Neon Codon DSA. They're a little technically different in that our Neon Codon DSA is set up to be referential. The Persyst DSA is bipolar. But again, broadly, you can see it visually. And so we use visual identification for real-time monitoring. We don't have a real-time quantification strategy yet, though that is something that we have talked about is developing potentially, everything's AI now, so I don't think we could do it if we didn't say AI at least, because people would laugh at us. But some bedside way to give you a Qmax in real time. But right now we use visual identification based on just a standard density spectral array.
Interesting. Okay, and then we have another question asking how ICP is monitored.
Yeah, so these patients were monitored typically with a bolt placed by neurosurgery. And then we basically pull all the physiologic data out of the bedside box. So we route that into our EEG machines. So this was invasive ICP, and then MAP was from an ART line, kind of standard ICU type monitoring.
Okay. And then for myself, just to recap, I'm still trying to wrap my brain around the neonates and the pediatric data. Is it true or is it different? Explain again, if you would, whether there's differences between the populations in the importance of the spatial spread of the MOs. I think in one population, it was important, and then in another, it was not.
So it was never the most important thing. So in both the PICU and the NICU, it was the Qmax, the strength of the oscillation that was most strongly associated with outcomes. And so again, that area under the curve quite convincingly shows this for the NICU. I don't have data, we didn't do this for PCPC, so I don't have data showing an area under the curve for PCPC, but it was the Qmax that was so again, if we look at
which is interesting though, right? Because if we're talking about, a global phenomenon of a failure of auto-regulation, in my mind, it seems more intuitive that the MO that would be associated with poorer outcomes would have a greater spatial spread.
Yeah, and again, I think that's true, that some of this we need to figure out more the physiology of, right? Because I think you could arguably have a focal disruption of cerebral autoregulation too, potentially, right? If you had
When you
a big like if you had a big stroke or something, I'm not sure that your contralateral hemisphere would be as affected. Though in the HIE NICU population, most of those patients did have, I mean, that's kind of by definition, neonatal encephalopathy you think of as a global injury, right?
Right, exactly.
So yeah, or our measure of the spatial resolution just isn't as good as our measure of the strength, right? That's another possibility, is it's a
But
problem
I
of
mean,
the
it
test.
a choice of which wavelet you used to
Yeah,
identify its presence, right? I mean, couldn't that
right.
be a
So
confounding
it's a,
factor? Yeah,
yeah, so it might be a problem of the test more than a physiologic thing.
yeah.
But it is true that if it was present anywhere, the strength of it, wherever it was
Was
present.
more important than the spread. That's really
Yeah,
interesting. Gosh.
yeah.
Okay.
Specific frequency. So the specific frequency, it tended to oscillate. I'll go back to this slide. So this is 30 seconds and this is 3 minutes. So it tended to oscillate. It tends to be in the 2.5, 2-minute range. There's not a, you can see here that different patients have different frequencies, but it all tends to be, this is 30 seconds, so minute is around here, 2 minutes is around here, so it tends to be a little below 2 minutes. But again, with exceptions, right? So that's typically we think of a 2.5 minute or something oscillation.
Yeah, yeah.
This
And
was
these are, I mean, ultra slow oscillations. What hardware are you using to measure that slow of an EEG pattern?
Well,
I
so I mean,
mean,
this
like,
is clinically collected with our clinical software. We sample in the ICU at 200 hertz. Again, your sampling frequency is more important when you're trying to look at ripples, right? And you um, run into your upper limit of analyzable.
are you using a
So
DC amplifier to record the data or no? I'm
no,
thinking of that lower
because
end of the data
yeah,
that
and
you're
again,
collecting.
well, because I think with that, and again, that gets to maybe it's the confusing terminology.
Okay,
It's not a DC shift. Like, you see with the seizure onset, you see that DC shift. We're not seeing
right.
that DC shift. We're seeing that oscillation in power, but the power is oscillating. These are clinically relevant frequencies, right? It's the oscillation in power of these clinically relevant frequencies. So it's not a DC shift of the
Got
background
it.
where you really
Yeah,
need to record that DC shift. You can see it, like you can see it in your beta band, right?
got it.
And so again, that's where the term oscillation, I think, becomes a little confusing. So yeah, so this is clinically collected. We didn't do anything special to collect
Okay,
this.
okay, which I think answers the next question, which was about the
Yeah, in terms
specific
of
technical parameters.
filters and sampling rates, I mean, this is collected at 200 hertz. That's our standard for ICU. We do much higher in the EMU, but for ICU, we do 200 hertz. And filters, we don't do anything standard with filters. Everything with filters now, I mean, you can do so much post-analysis with filters and everything. But in terms of sampling rate, it's collected at all these data were 200 hertz collected on commercially available neon code and recorders.
Yeah, okay, that's helpful. Yeah, but this is really interesting because I mean, that's a nice clarification. This is not DC shift. These are changes in the power across all of the frequency bands, and it's a slow oscillation that you're seeing in the EEG across all of the EEG.
Mm-hmm. Mm-hmm. And so the thought is, yeah, as you lose the auto-regulation buffer, there becomes this hypersynchronicity between your perfusion pressure, your ICP, and your EEG power,
Yeah.
for
And
reasons
something, yeah, is causing
as
a
yet
global
unknown.
fluctuation in
Yeah.
power. Yeah, that's really interesting. And yeah, auto-regulation. Do you have theories about the role of the thalamus in this phenomenon? Is there
Yeah,
anything?
I mean, yeah, anything generalized, it's hard to say generalized without thinking thalamocortical networks, right?
Right. Yeah, that's where my
Um,
mind went.
Right. So, is it? I think there's a couple possibilities. So one is it loss of that thalamocortical network, right?
Right.
Do you
Right.
lose the thalamic Do you lose the thalamic control or the thalamic pacing of your brain? I think that's possible. One theory is that this is a kind of last hope effort. You know, if you have a severe brain injury, this is your way, a way for your brain to kind of try to restart, if you will, right?
Mm.
So, and it was, again, like we did see it in patients who in the NICU, right? So isolated deep gray injury also had like just as strong as other things. So even if
Yeah,
there wasn't a lot of cortical injury, so I think that does support the possibility that it could be related. And again, anything generalized we think of course, you jump to the thalamicortical. So yeah, I think it's possible. I'm just very hesitant to make any kind of
sure.
firm
Yeah,
assumption, right?
yeah. But in terms of the clinical relevancy, I mean, you're using it as an indicator, yeah, to treat. Um, and we still don't necessarily know why. We can speculate, but it's still unknown.
Yeah, I would say, yeah, typically we still wait for seizures, but we might, when we see this, have a quicker reaction I think we take it into, I don't know if, I'm hesitant to say that we aggressively treat it, but I think we, in the PICU at least, take it into account when making treatment decisions.
Yeah,
Again, the NICU is totally different. So I don't know what to make of it in the NICU really.
yeah,
But in the PICU, because it was so strongly associated with seizures and difficult to treat seizures, when we see it, we might be a little more apt to give something.
yeah. Okay, that's interesting. Okay, we have a couple more questions. When is are those the same as ultrasound oscillations? I assume referring to MOs.
I am not super familiar with ultrasound oscillations. So whoever asked that, if you,
Yes,
I'm not totally sure
it
ultrasound
was,
oscillations.
yeah, it was asked anonymously, so I'm not sure.
Okay,
Maybe the person can write a clarifying
yeah.
comment on the question. There's another question about DC shift. May I ask about the DC shift filter? So maybe we need another clarification that what we're looking at is not DC shift. That's a
Yeah,
different
again, I
thing.
don't think that this is DC shift in that, again, we're seeing it like across the power of every frequency band in the EEG, right? And so I don't think that this is related to just a DC. Like, I think I'm not going to say it's completely separate from a DC shift, right? But I think it is more than just a DC shift, in that like it's oscillating across every, the whole EEG spectrum.
Right. Yeah, DC shift is something completely different. Those are slow
Yeah,
changes
and
in
and there
just
might be
that
some,
frequency band,
right.
right? Yeah,
There
yeah.
might be some overlap between the physiology of the two. Like again, I'm not going to say that it is fundamentally different, but I don't think that's like just what this is due to.
Right. Yeah, I agree. Okay, so the person that asked about ultrasound oscillations meant to write ultra short oscillations. So are they the same as ultra short oscillations? Does that
Um,
help?
for short oscillations.
Still not exactly sure what they're
I'm
asking.
not totally sure
Okay.
what
Okay.
yeah, I'm not totally
Um,
sure what ultra short oscillations
I haven't
are
heard that term either.
either. Yeah.
Yeah.
Um, I'd be happy to chat about that. I'm not totally sure.
Okay.
I mean,
Maybe they'll,
so there is in the literature, we are not the first. If you look back, you can find pictures of DSAs with a pattern like this on it. So I'm not going to claim that we are the first people ever to discover this. I think we've gone a little further with the quantification of it,
Mhm.
but it's had a lot of different when it's been described because it's not been standardized. It's had a lot of different terminologies applied to it
Like
to
so
these
many things in
oscillations.
EEG.
Yeah, right.
Yeah.
Yeah,
Yeah.
exactly. And so again, I'm 100% sure that other people have described it using other terminology in the past. Like,
Okay. Yeah.
absolutely.
So there's another comment here. I see these oscillations all the time. Thank you for giving it a name. I feel like these go away with stimulation or arousals, don't they? Does the state of the patient matter?
So I have seen it. I have seen it state dependent. And that's a good question. In these patients, it did not tend to be state dependent. Well, in a lot of these patients, they didn't have state, right? They
I
didn't
was gonna
have
comment that
state.
they're in the ICU.
Um,
They don't
right.
have a
And
state. They're sick.
so, yeah, like, so I'm just gonna go back and like, this is a 12-hour pattern, right? So there is not a state. I
There's no
have seen it
arousal. Yeah.
in some patients, say 3 months after. So, like, there's one patient we have now still floating around our hospital who's a few months out from I forget, a cardiac arrest or something. And she does have, I mean, she has this pattern in a state dependent way. Um, we are not treating it because, like, it just seems, because when it is state dependent, I don't know what you do with that. So yeah, I have seen it state dependent. We also, you can see this, and I'm hesitant to get into this because we haven't done much research on it. You can see it sometimes with like sleep features, like sleep spindles can be very mechanical like this. And again, back to the thalamocortical theory, is that some thalamocortical dysregulation where things just kind of get very weird. So yeah, in these patients, they tended to be injured and sick enough. They were not state cycling, so it wasn't state dependent. But yes, I have seen it as a state dependent phenomenon, and I don't totally know it, honestly, if
Yeah,
you
I
will.
mean, in my mind, it makes sense though, right? Because I mean, so what we're talking about is a normal physiological process of oscillation that is state dependent, probably in a healthy person, right? Like it's something that the brain is doing, right? These oscillations can be seen in normal patients, but you're working with populations that are in the ICU who are brain injured,
Mm,
who don't have states and there's no arousal, they're ill, and you're
right.
seeing these patterns, right? Either globally or not, but you're seeing them consistently, and they are correlated with poor outcomes. So
Hmm.
you could, I mean, in my mind, it's safe to say that, like, yeah, they may show up in other patients in other states, but when you see it in these conditions, that's a sign that
Yeah.
something bad is going on, because what is normally a normal physiological thing that the brain can do, now it's kind of stuck in that state. It's having
And
a
I think that,
problem.
yeah.
Yeah.
And I
And
think the
so,
NICU data kind of support that too, where in our control group, it was not zero, it just was lower, right?
right, right. So
Um,
everything is context dependent. In this context, under these conditions, with these certain kinds of patients, MOs are they're an important clinical indicator of what might be going on with your patient and what you should therefore look for.
right, yeah. And like I've actually seen it in the EMU, like in Rett patients or patients with epileptic encephalopathies, they can do weird stuff like that. I'm not sure that's the same though. I'm not sure
Yeah,
that's the same as what this is.
right.
And so that's where some of the quantification I think helps, because as with raw EEG, things can look similar but be pretty
Exactly.
different physiology.
That's right. Yeah.
So yeah.
We have a question. David Klein would like to ask a question. So, David, you can unmute and ask your question.
Hi there. Thanks so much for this talk. A question I had was if it's if it's increased risk of seizure, right? How do you avoid over treating? Because like in an encephalopathic patient, right, you could easily like add benzos or seizure meds, and then the EEG will get like a little bit less rhythmic, but then
Yeah.
clinically they're even more depressed. So like at what
Yeah.
point do you draw the line and say if they're not on seizure meds, yes, you should add it if there's no clinical change and you see this cyclic alternating pattern of encephalopathy?
Yeah. I think honestly, I think this is a marker with the data we currently have, to me, not to independently treat this pattern, but to label this a high risk patient, right? And
Okay.
so, when we have patients in the ICU, we'll have a bunch of patients up, and you have some that you're low risk and some you tell your techs as you're going home, keep an eye on this kid, right? I think probably at this point that this is a marker of keep an eye on this kid. Because I agree, I don't think we have the data to support like independently treating. And especially, right, as with a lot, like even if you treat this early and prevent a seizure, are you going to improve outcomes? I don't know. And so I would be, I might have oversold it a little bit in that I would not treat the pattern, but I think it can help you build your clinical context of the patient.
Okay.
Maybe the way PLDS or some of those other EEG patterns, you're not necessarily going to treat that, but you're going to pay more attention to that patient. I think probably it falls under that category for now. Again, in the PICU, as we get more data, we might be able to make more clear recommendations. But for now, yeah, it's an association.
Okay, yeah, that's what I thought.
And then in the NICU, it's like totally different, right? Who knows? Babies are weird again.
Thanks.
Yeah, that makes sense. Thank you for your question, David. Okay, we have gone over our allotted time. Thank you guys so much for your participation. It's fun for me to field questions during the talk, and Dr. Tomko, I hope for you as well. But really,
Yes.
it was a very interesting
Oh.
talk. I appreciate your time very much.
Yeah, of course. I hope people enjoyed it.
Yeah, for sure. So once again, thank you, and we'll end there. Have a great
Thank
day,
you.
everybody. Bye-bye.
Thanks.